Background. Mild traumatic brain injury, or MTBI, is common in youth, with 30% of cases having persistent post-concussive symptoms 1 month post-injury. MTBI in adults often reveals changes to things such as energy metabolism and neuronal viability, as measured by creatine and N-Acetyl-Aspartate concentrations in the brain, as well as cognitive function. Yet the nature of these neurobiological changes in youth with symptoms is not well understood. The dorsolateral prefrontal cortex, or DLPFC, plays an integral role in cognitive functioning and shows changes in N-Acetyl-Aspartate concentrations in youth with past concussion. Therefore, our objectives were to compare 1. DLPFC concentrations of N-Acetyl-Aspartate and creatine, and 2. Cognitive functioning between symptomatic and asymptomatic youth approximately 40 days after MTBI and in controls without MTBI. Moving to methods. This is a secondary analysis of a registered clinical trial listed here. We had 3 groups: symptomatic, those with MTBI presenting with persistent post-concussive symptoms; asymptomatic, those no longer presenting with symptoms; and controls, those who had not had an MTBI. We assessed post-concussive symptoms using the post-concussive symptom inventory, and participants symptomatic or asymptomatic based on this. Cognitive function was assessed using CNS vital signs, a computerized cognitive battery assessing core cognitive abilities. The Neurocognitive Index, or NCI, is a summary score of this battery. Creatine and N-Acetyl-Aspartate concentrations were measured using magnetic resonance spectroscopy. The voxels were positioned within the DLPFC, pictured here in panel C. Moving to results. As you can see here from these box plots, for both creatine, here on top, and N-Acetyl-Aspartate, on bottom, the symptomatic group had significantly higher creatine and N-Acetyl-Aspartate concentrations than controls. This dip was present in the left, but not the right DLPFC. Moving over to the table, we can see that for cognitive function, the Neurocognitive Index was not different between these groups. Notably, these scores were within the normal function and capacity range for these tests. On to discussion. Higher creatine in symptomatic participants may be due to increased energy demands and may have neuroprotective effects, such as creating a stocked reservoir of phosphocreatine in the brain to manage recovery. Next, higher N-Acetyl-Aspartate may be related to delayed recovery. In adults with MTBI, N-Acetyl-Aspartate increases initially but returns to normal concentrations later. Adults show delayed recovery post-MTBI, so this may be an indication of delayed recovery. Finally, we did not see differences in cognitive function across the groups, and scores were within normal range. Future studies should consider large-scale longitudinal magnetic resonance spectroscopy investigations in youth with MTBI to better understand these neurochemical differences.